Professor of Pediatrics at the University of Louisville School of Medicine. She is the Medical Director and Chief of the Norton Children's Pediatric Protection Specialists and COSAIR Charities Division of Pediatric Forensic Medicine. Dr. Curry received her medical degree from the University of Louisville School of Medicine and completed a residency in pediatrics at Medical College of Wisconsin before subspecializing in child abuse. She sits on the legislated Kentucky Child Fatality Review Panel and provides training about recognition, intervention, investigation, and prosecution of child maltreatment to a wide variety of academic and professional audiences. Something you may not know about her, she is the founding member of the Face It movement, which is a multidisciplinary community action group that is committed to ending child maltreatment in Kentucky over the next decade. So thanks for joining us, Dr. Curry, and she will be discussing pediatric abusive head trauma. So turn it over to you.
Appreciate the introduction. Give me 1 second to share. And let me just hide my toolbar here. Hopefully you can see my screen. Give me 1 moment here.
Yep, we can see it.
Thank you. All right. Well, good afternoon, everybody. As Dr. McDonald said, I'm Melissa Curry. I'm a child abuse pediatrician, and we're going to talk about pediatric abusive head trauma today. I have no disclosures. And I do just take a moment before all of my presentations these days to ask for feedback from folks. I have reviewed this content through a diversity, equity, and inclusion lens, and I try to avoid stereotyping content. But if you identify a way that I could do better, please let me know. And you can either put it on the course evaluation, or these are my 2 email addresses here. So we are going to talk about the signs and symptoms specific to pediatric abusive head trauma, but also child physical abuse in general. We're going to talk about the components of the appropriate medical evaluation and follow-up of those patients. We'll talk some about the risk factors for and prevention of abusive head trauma. And then we'll talk a little bit about our legal and ethical obligations regarding reporting suspected child physical abuse. So just to start talking a little bit about the terminology that we use, because it has gone through a lot of mutations over the years. Some people still refer to this as non-accidental trauma. We used to call it shaken baby syndrome, sometimes shaken impact syndrome. And we really have stuck with the term abusive head trauma since about 2009. That's when the American Academy of Pediatrics published the paper that, or the guideline that asked us to pivot to using the term abusive head trauma. And there are a couple reasons for this. So first, the term shaken baby syndrome implies that this is something that only happens with babies. And we see this regularly in kids who are toddler age or sometimes even school aged. So we don't want to artificially limit our, group of patients that we're keeping this in the differential for by using the wrong term to describe it. The other issue is that while shaking is clearly the most common mechanism that is involved with abusive head trauma, we know that many victims are shaken and have impact. If there's impact alone that has a rotational component, that can be the mechanism. And then crush injury is an additional mechanism that can be involved with abusive head trauma. So we are trying to not artificially restrict the age range and not limit ourselves to only one mechanism. And that is those are the main reasons that we got away from using the term shaken baby syndrome. Now, if we are doing education out in the community, it is perfectly appropriate to continue to use that term because I think that's the term that folks recognize. It's more, in the setting of medical record documentation and testimony and things like that, that we want to use the appropriate term. So just a little bit about our statistics here in Kentucky. We have about 75 kids who die under circumstances of maltreatment each year in Kentucky. That number varies significantly year to year, and it seems to be getting worse here recently in the last few years. On average, we have about 150 kids who are involved in what we call a near fatality. So a near fatality is actually defined at the federal and the state level, and that's an act which, as certified by a physician, results in a child being in serious or critical condition as a result of their alleged maltreatment. So any child who ends up in the intensive care unit, and even some of the children who don't go to the ICU but are still in serious condition, will be designated as a near fatality. And that is important because it affects how CPS performs their investigation. There are additional levels of oversight and requirements that have to happen if it's a near fatality. And that also is a number that gets reported to the feds every year. So this probably does not come as a surprise to folks, but Kentucky is consistently one of the highest, has one of the highest child victimization rates in the country. Over the last several years, we have varied between having the highest rate in the country to being 14th. I believe currently we are 14th. So abusive head trauma is the most dangerous and deadly form of child physical abuse. It is very rare, though, for a child to die from or be permanently disabled from maltreatment the first time they're abused or neglected. Now, there are exceptions, certainly, but more than half of the children who are diagnosed with pediatric abusive head trauma will have some evidence of previous injury. And so healthcare professionals are in a unique position to recognize and intervene on behalf of these kids. And it can be tricky with abusive head trauma because, as we'll talk about, a lot of the presenting signs and symptoms can be vague. Often the children don't come with the history of what has just happened with them or happened to them. And so we have to have, a low threshold or a high index of suspicion. And that is duplicative. So part of the reason that healthcare professionals are so important, for this issue is obviously first and foremost, we're in a position to help make sure that the appropriate evaluation is performed right away. So we're going to talk about bruising, and we will talk about, that bruising in babies in particular is an actual emergency, and those children need to be sent, or those infants need to be sent to the emergency department for a full evaluation. So learning to recognize the warning signs and recognizing the urgency with which these children need to be referred is really important. Another interesting kind of I guess just thing to keep in mind is that we as healthcare professionals are often the folks who have the last opportunity to obtain an unguarded history from caregivers, meaning before they are aware that abuse is being suspected. And I think that it's important for us to recognize that we have that opportunity, because if we know the questions to ask and can document the answers clearly, that can make a significant difference for how the case unfolds from an investigative standpoint. And then finally, as healthcare providers, our concerns are sometimes weighted more heavily by investigators because, we bring credibility to the table from our experience and training. And of course, there are lots of different roles. I am sure that I have missed some huge groups, but these are, just some of the more common healthcare professionals who interact with these kids and their families. And, we're all important. Anybody who has contact with children. So abusive head trauma is really referring to the brain injury itself that is caused by a rotational or angular force. So by rotational, and I have a picture coming up here, I think on the next slide, but we're talking about the head moving in an arc. And if you can imagine a baby being shaken violently, the neck is the pivot point. So any curve that the head follows is going to be just that, a curve. It's not a linear non-rotational kind of thing. So we will see most often subdural hematomas, and those subdurals tend to be smeared over the convexities. They can be unilateral or bilateral. They tend not to be the focal subdurals that we will see right underneath a skull fracture, but rather diffuse over the convexities. We may see retinal hemorrhages, and some of the retinal hemorrhages that we see are very specific for abusive head trauma or other high energy mechanisms. We may see scalp bruising and skull fracture, but all of those things, the subdural, the retinal hemorrhage, et cetera, are telling us how the brain injury occurred. It's the injury to the brain tissue itself, though, that is causing death and disability, and that's what's usually causing the symptoms in the child as well. Abusive head trauma is most often triggered by crying when it occurs in infants. In older children, like 2, 3, 4-year-olds, the most common trigger is toileting accidents. And again, abusive head trauma is not typically a one-time event. So the way that we get injury, if you can look at the drawing here, we have the surface of the brain, we have veins that are draining blood into the superior sagittal sinus here. And if you remember, this sinus is fixed to the inside of the skull. So during a violent shaking event, the sinus is moving in tandem with the skull, but the brain is sloshing around. And as many of you may know, we have more space between the outside of our brain and the inside of our skull as infants. And there are some other anatomical differences as well. But the brain is going to be moving at a different rate and sometimes in different directions than the sinus. And so these bridging veins here that drain into the sinus will tear and bleed, and they bleed into the subdural space. And this gray structure is just the dura there being reflected back. So the subdural, again, tells us how the brain injury occurred. The subdural itself is generally not what is causing the problem for the child. Now, there are some exceptions to that. If the subdurals are large enough that they are actually space occupying and putting pressure on the brain in a way that's, somewhat similar to what an epidural will do, then we can get signs and symptoms of increased intracranial pressure and so forth associated with that. But more often than not, the subdurals are actually thin and don't require neurosurgical intervention to drain them. So most cases of abusive head trauma, the subdurals themselves will just spontaneously resorb without intervention at all. In some cases, and we don't know why, we are not able at this point to predict which kids this will happen with, but in some kids, rather than resorbing it, it will become a chronic subdural hemorrhage. So that fluid will stay in the subdural space and persist there for some period of time. And then sometimes, as I mentioned, they need to be surgically drained. So this is an image here in the top left that shows you the angular or rotational component during a shaking event. And, when it comes to the subdural, this is just a cross-sectional view. So you have the brain down here, you have the bridging vein here. This obviously is not in proportion, and you get the subdural bleeding here in the subdural space. And so when there is acute or new blood, that is most easily seen on a CT scan. And that is why a CT is the cornerstone is a cornerstone, excuse me, of our screening for abusive head trauma. So when we are doing the CT scans, we are specifically looking for subdural hemorrhage, and then obviously anything else that's on our differential diagnosis for whatever combination of signs and symptoms that the child has presented with. So just to talk for a second about why babies and young children are at significantly higher risk of brain injury from this kind of mechanism compared to adults. And there are some anatomical differences. So the inside of the infant skull is actually smoother. There are fewer nooks and crannies to kind of hold the brain in place. There is more extraaxial space in babies compared to adults. There also is a condition called benign enlargement of the extraaxial spaces, or BESI, where they're even larger than typical. But that gives the brain more space to move inside the skull and to actually gain acceleration and to then decelerate rapidly. Then we also have the relatively large head to body ratio and relatively weak neck muscles, so that the infant's ability to resist those forces is practically nil. And then, of course, the brain is still developing. So we don't have all of our myelin laid down yet. That happens over the course of the first 3 years. So in the absence of myelin, which is fatty, we end up having more water. So the infant brain has 25% more water than an adult's. So think about like underset jello. So the brain tissue itself is more prone to injury. So back in 2001, the American Academy of Pediatrics released this statement as part of their technical report on what was then called shaken baby syndrome. And the AAP continues to stand by this statement, and that is that the act of shaking leading to shaken baby syndrome is so violent that individuals observing it would recognize it as dangerous and likely to kill the child. And the reason that it's important for us to recognize the degree of violence that's involved here is because often the history that is provided to explain the head trauma in our patients has been minimized or fabricated completely, and it will often tempt us to believe that something more subtle happened to the child to cause the injuries rather than violence. And we really have very good data from lots of different sources and perspectives, whether it's perpetrator confession data or biomechanical, modeling data and clinical data. All tells us that these are injuries that we see with violent forces. We can see other associated injuries sometimes that can include metaphyseal fractures, also known as the classic metaphyseal lesion, or CML. Those fractures are sometimes also called corner fractures or bucket handle fractures. So metaphyseal fracture, corner, and bucket handle are all the exact same fracture, and they are very specific for inflicted child physical abuse with very rare exception. They've been described in a couple of cases of serial casting for infants that have club foot. They've been described once or twice from very difficult deliveries. It was actually C-section deliveries, but otherwise they're very specific. We can also see rib fractures, with the ones that are posterior being the most specific for inflicted injury, but really in an infant, most rib fractures, posterior, lateral, or anterior, are not going to be easily explained from routine childhood accidents, drops, falls, rolls off the couch, things like that. And, with abuse, we can really see fracture of any bone in the body. We also can see bruising, and we're going to spend a lot of time talking about bruising. And we can see internal abdominal injury, and there won't necessarily be bruising on the abdomen, even though there sometimes can be life-threatening intra-abdominal findings. So one of the things to really keep in mind when it comes to pediatric abusive head trauma is that there sometimes is nothing on the outside of the baby to indicate that this is an infant that has been traumatized or abused. So one of the things that I say very often to learners is that, children can look amazing on the outside and be incredibly broken on the inside. And that is why our complete medical evaluation is so critical, so that we can pick up on occult trauma, with occult, of course, meaning it's not obvious from the outside. So we can't rely solely on a normal physical examination to rule out the possibility of abuse. So before we launch into talking about bruising, I do want to talk just very briefly about a handy little trick to help us determine if something that we see on the skin is truly a bruise or not. And this won't, distinguish all of them, but it will at least help us distinguish vascular or inflammatory lesions from bruising. So when this is a typical hemangioma, and I'm just demonstrating how I've applied pressure here with the pen, and you can see how part of the lesion completely blanches and goes away. And then so I apply the pressure, you see the blanching, and then all of it comes back again. So that is intravascular blood that's part of that lesion or discoloration, and inflammatory conditions like rashes and so forth will do the same thing. If a lesion blanches, it is not a bruise. Contusions is another word for bruise. Those are color changes that we can see at the surface of the skin from blood that has extravasated from damaged blood vessels. It's in the interstitial tissue, and it is being broken down over time by the body, and that is what leads to the color changes that we see. If we apply blanching pressure to a bruise, you may still see some degree of blanching, but you will still see stipples of discoloration under the blanched area. So if it does not blanch, it is much more likely to be a bruise. Now, one caveat to that is that there are some birthmarks that also won't blanch. And so this trick will not help us distinguish, for example, between congenital dermal melanocytosis or slate gray nevi, or sometimes cafe au lait spots can look a little bruisy, and the blanching trick won't help with that, but it will at least help us distinguish inflammation. So we're going to talk now quite a bit about bruising. And so as you would expect, we're going to have photographs of bruises in children. And some of these are graphic and disturbing as they depict injuries in young children. So I just want to give folks a heads up. And obviously, if you need to look away or take a break, do whatever you need to do to take care of yourself. So we're going to talk about the 10-4 faces P bruising rule. And this started out as the 10-4 bruising rule, and it was based on data that was actually gathered at our own hospital here in Louisville. The additional data that then helped the rule become expanded and more refined was also based on cases that were from here, as well as multiple other centers. 10-4 faces P is a screening tool. It is not a diagnostic tool. So we use this mnemonic to help us know when we are seeing a bruise that may be a sign of abuse. It's a bruise that needs further evaluation. It does not in and of itself, if a child screens positive, mean absolutely that this is an abusive finding. It is only a screening tool to identify high risk. So the TEN of 10 stands for torso, ears, and neck. And I think it's really important to make sure we're all on the same page about what constitutes the torso. So if you can imagine one of those old-fashioned plastic baby dolls, and you pluck off the arms and the legs and the head, what you're left with is the torso. And I know that's a creepy visual, but it tends to stick with people. So chest, abdomen, back, buttocks, genitals, the whole thing is the torso. So any bruising to any part of the torso. E is for ears, N is for neck, And so that's the 10 component. And then the 4 is referring to any child 4 years of age or younger. So 10-4 bruising in a child 4 years of age or younger, or any bruising anywhere on an infant who's 4 months or younger. Now, really, it is less about the chronological age when it comes to babies, and it's more about what their developmental capability is. So until children or babies are starting to pull up and take steps with support, call that cruising, they do not start earning their own accidental bruises. So bruising in babies that are not yet independently mobile is very, very rare. And it doesn't have to be in the 10-4 region. It can be anywhere. So any bruise in a baby is considered high risk. And unless it was an independently observed incident like a car crash or something, or something caught on video at Walmart, something like that, it needs the full evaluation. So if you don't remember anything else from the presentation today, please remember that bruising in babies isn't normal, and that if we see it, it's a medical emergency, and that child needs to go to the emergency department to have the full evaluation, which we'll talk about later. And I just have a few examples here, and then we'll move to the faces P part. This is an example of torso bruising. It also, incidentally, is an example of patterned bruising, and that's what the P stands for. So we have multiple overlapping parallel linear contusions to the buttocks of this young child, and that's from multiple blows with an open hand. In this infant, we can see considerable bruising down in all of the nooks and crannies of the ear. All of these little spaces have their own names. And we also can see a little bit of bruising on the side of this child's cheek. This was a 7-month-old who was kicked in the side of the head. And this child had a skull fracture and an underlying subdural hematoma as a result of that contact injury. So that would be an example of abusive head trauma that did not involve shaking. It involved impact, but it was clearly not accidental. And then this is an example of neck bruising here. This was an infant who was violently shaken. He came in having seizures via EMS. He initially was stable enough that he just needed nasal cannula, but within an hour or so, he deteriorated and had to be intubated. He ultimately survived his trauma, but he had significant neurological, frankly, devastation as a result of his traumatic brain injury. So he is unfortunately now dependent on others for all of his cares. This infant also, as you can see, has some bruising on his chest. So that would be examples of torso bruising. So that's the 10-4 piece. Faces P we'll go through more quickly. The F stands for frenulum. So the frenulum piece is the one piece that we're not actually talking about bruising. We're talking about a tear or a laceration to the frenulum most often, although you can sometimes see contusions of our frenula. The 3 main ones that get injured are the one behind our upper lip, that's our maxillary, the one behind our lower lip, that's the mandibular, and then the one under our tongue, that's the sublingual. We also, the A stands for angle of the jaw, and I'll show you some examples of that. One could argue that this bruise here that I was labeling as neck bruising is actually angle of the jaw bruising. It really doesn't matter how you describe it. They both are part of the rule, and they both are very worrisome. The C stands for cheeks, and we're talking about the facial cheeks here, and we're talking about the soft fleshy portion. E is for eyelids. S is for subconjunctival hemorrhage. I'll say more about that in a second. And then the P is patterned. And so we're going to run through some different examples here coming up of 10-4 faces P bruising. Now, one of the things that is so wonderful about this screening tool is that it takes the burden off of us as providers to decide whether the explanation we're being provided for the bruise or the finding is actually plausible. It doesn't matter if it seems plausible. If it screens positive for this rule, it needs a full evaluation. And by it, I'm talking about the injury, not the child. So these are some examples of torso bruising. For the sake of time, I'm not going to tell you the full stories for these two kiddos, but essentially both of them had significant life-threatening intra-abdominal trauma. This child was sitting up sucking on her pacifier when she was brought to the ER for evaluation by her mom. And we did the full workup for this baby. This was quite a while ago, several years ago, actually before 10-4 rule was published. And we did the full skeletal survey. That one was fine. We did the head CT. That was fine. We did the screening abdominal trauma labs for occult injury, and her liver enzymes were through the roof. That got her a CT of her abdomen, and she had a grade 3 liver laceration sitting in there. The only external evidence of injury was that small bruise on her belly. She had a completely normal belly exam. She did not cry when her belly was palpated. Her liver edge was not down. Her physical exam would not have led us to believe that she had such a significant intra-abdominal injury. Her follow-up skeletal survey done 2 weeks later did have healing rib fractures. So what we do know is that rib fractures in particular, when they're brand new, can be impossible to see on x-ray, even when we look in retrospect. And so we can pick up to 30% more fractures by doing that repeat skeletal survey in 2 weeks. This child was assaulted by his mom's boyfriend in the course of a domestic violence incident. The boyfriend actually held the child by the nape of his neck and punched him in front of mom as a way to terrorize mom. And so you can see this extensive torso bruising here. This too is a pattern. The short parallel linear contusions is actually a pattern that we get from a punch. And those linear bruises are indicating the spaces between the fingers that are curled into a fist. This child was discovered because a neighbor called 911, and he was transported emergently. He had pancreatic laceration, duodenal hematoma, and liver laceration, required emergent surgery, blood transfusions, but did ultimately survive. And thankfully, for this child, his brain was actually okay. But those are two examples of torso bruising. Ear bruising can involve any part of the ear. This is a child that has a crush injury to his ear. He was picked up and thrown by his ear, and we know that because he told us that's what happened. This is a 2-year-old who you're going to see another picture of here in a minute, but he ultimately died from abusive head trauma, and you can see the subtle kind of petechial little bruises. He even has a bruise on his earlobe here. The ear bruising is not necessarily going to jump out and grab us. We have to look specifically for it and look carefully in order to not miss it. But even the tiny little petechial bruises are high risk and justify a complete workup. I include this little gal because her ear bruising looks red, and it was initially thought to be a rash and inflammation, but when you applied blanching pressure, it did not blanch out. She actually had other findings that were very concerning for abusive injury. She too had a liver laceration and was in the PICU. This is the little guy whose ear we just looked at with the little petechia. And this is an example of neck, or you could call this jawline bruising. When you see bruises off to the side, now I'm not talking about a single bruise in the midline here. That is a common accidental injury in mobile kids. But when we see bruising on the sides at the jawline or neck, that is very ominous and should get our attention. I have yet in my career so far seen a child with jawline bruising that we could confirm was accidental. just about every child, if not every child I've seen with this kind of bruising, has had other injuries that were independently diagnostic for abuse. This is a different kind of neck bruising. And while the history was that this child woke up with the bruise and had slept on a Lego block, what had actually happened is that his mom's partner had gotten up in the middle of the night, frustrated with his crying, and strangled him. We most often with strangulation injury will not see any bruising associated with it. So when we see bruising, especially this severe, we take it very seriously. And this child's incredibly lucky that after he was strangled, he actually woke back up. Because not all kids obviously are able to do that. So we've done the 10. Now we're talking about the part where any bruising anywhere in a child who's not independently mobile, 6-week-old, well child check, 2 tiny little green bruises that mom blamed on the car seat buckle. It really didn't matter if we thought that that was a plausible explanation or not, and I could go through all the reasons that I would doubt that explanation, but the long and short of it is that even if it sounded perfectly reasonable, we would still do the full evaluation and we would do it emergently. And that's exactly what this pediatrician did. She sent this infant to the emergency room despite an otherwise completely normal exam, other than that umbilical hernia, obviously, and this baby had multiple broken bones. The only external evidence of her injuries was the bruising. And then an almost identical story here. This is actually the back of the thigh of a 4-month-old. Also a well child exam, seen outpatient, no concerns with family. Family had no concerns, but had a bruise, was sent for the evaluation, had multiple broken bones. So even tiny, subtle bruises, and even tiny, subtle bruises that have an explanation that sounds reasonable, justify the full evaluation. So remember that those who don't cruise rarely bruise. We'll go quickly through examples of frenulum tears. So the sublingual frenulum gets torn and or bruised from something being forced violently in the mouth. That can be a bottle, a feeding spoon, it can be a body part. Any number of things can cause that, but it does require pretty violent forces. The maxillary frenulum tears come from either something being mashed against the mouth as it's being forced in, or just a direct blow to the mouth can actually cause a shear injury where the lip is actually sort of, violently moving sideways and tearing the structure. And then here are angle of the jaw bruises. So I used this little guy for both neck and angle of the jaw. This is the same child here on the bottom. She came in again with this bilateral jawline bruising. She also has a patterned bruise on her cheek here, which is a human bite mark. And all 3 of these children were victims of abusive head trauma. Then C is the cheek for fleshy parts. So we're talking about the soft portion of the cheek here. For this little gal, if she had just come in with this bruise here at the top that is over her cheekbone or a bony prominence, if she had a history of falling against a coffee table and she's independently mobile, that wouldn't necessarily concern me at all. But the soft portion of the cheek is a different story. And the data pretty clearly teases that out as significantly higher risk. E is for eyelid bruising. Now, one of the things we see sometimes as a misstep here is that these marks are not recognized as bruises and are thought to be scratches where the child has, scratched their eye with their own fingernail, and that certainly can happen. But abrasions will show disruption to the surface architecture of the skin. You will often see, the displaced skin curled up at the edges of the abrasion, like a collarette of scale. If you are seeing redness or, other discoloration that does not blanch and does not have disruption of the surface architecture of the skin. That is a bruise, and that is much more significant and more concerning for inflicted injury. And then it goes hand in hand sometimes with the subconjunctival hemorrhages. So those are to the white part of the eye. We have some interesting new research that just came out earlier this year. It was a really well done study of children that actually were patients at a crying clinic. It was basically a colicky baby clinic that they had parents record the hours that their children were crying at home. And these are kids that cried well outside the norm for the intensity of their crying and the amount of time that they cried. Long and short of it is that even in babies who are crying constantly, and also that this was a longitudinal study where parents kept logs. So they kept logs of children who were coughing and children who were vomiting. And all of those Valsalva type maneuvers that we used to think were reasonable explanations for subconjunctival hemorrhages in children turn out to not actually cause them, at least not according to this study. And that came out this year. And then Mary Clyde Pierce's data on 10-4 faces P that was published years ago is showing the same thing, that outside of the neonatal period, that first few days after delivery, if we're seeing a subconjunctival hemorrhage, that is actually risky enough that it justifies a full evaluation. So our previous notions of Valsalva causing it in babies and young children the way that it can in adults turns out not to be supported by the literature. The P stands for pattern. Here we have 4 bruises kind of in an arc, and those are from knuckles. Any kind of pattern, a pattern injury is essentially an injury on the surface of the skin that gives us a hint about what object was used to cause it, because it leaves behind a negative impression. So slap marks are one of the most common pattern injury. Loop marks are probably the second most common. Loop marks can come from anything that's thin and flexible, that's bent over on itself and used basically as a whip. Any other object, theoretically, if it's flexible enough to conform to the contours of the body, can leave a patterned injury. And we're going to just go through some examples. So I've talked already, you saw the picture earlier of all of the bruising to the buttocks on the child on the 10-4 slide that was parallel linear contusions. And that's essentially what we're seeing here on the side of this child's face. What we're seeing is bruising around the perimeter of the object that impacts the skin. So we're getting a negative impression. And so this is what it looks like in real life. This is the same child. It was just 2 pictures taken, some hours apart. He had a different outfit on and different lighting. But the history that he had for this bruising was that he ran into the wall. And this was the wall. The person who brought him for care was not the person who was with him when this happened. She was simply reporting what she was told happened. That's a really important detail to get when we're taking histories from kids with injuries is, are you telling me something that someone else told you, or are you telling me this is something you witnessed, or are you telling me that this is something you heard or saw, heard or like saw the result of, but didn't see it actually happen, and you're telling me what you thought happened. So for example, if a child comes in with a history of having rolled off the bed, did they actually see the child roll off the bed, or did they just hear a thump and find the child on the floor? Those kinds of things end up being really important to document. So this is one pattern injury, the slap mark, and here are many other examples of the slap mark. Here's another one on the buttocks, parallel linear contusions. These do tend to be most often on the left cheek for children when they're on the face because most people are right-handed. For this child with darker skin pigmentation, you can see that her linear contusions are very subtle. They're difficult to see. They're also difficult to photograph. Children with more melanin in their skin, it can be very difficult to not get this flashback or shiny part from a flash. And so that's why using ambient lighting instead of the flash can be helpful. This child had eyelid bruising as well. This was a patient that was admitted for a completely unrelated reason. I think it was, diarrhea or something like that. And it was actually a third-year medical student who saw the patient after she'd been admitted and had been in the hospital overnight. The third-year medical student actually turned on all the lights and did a careful skin exam and found the bruising. And I think sometimes our desire to be family friendly and patient friendly and keeping our lights low and our voices low in the middle of the night, to help people be comfortable, can sometimes interfere with our ability to pick up on findings. So we do have to remember to turn on all the lights and do thorough exams on kiddos. And then again, this is the same kiddo, multiple blows with an open hand. And I show his picture again just to spend a quick second to talk about physical punishment or corporal punishment. Hitting children in the United States as a form of punishment is legal in all 50 states. So we are allowed to hit children, but what we are not allowed to do is injure them in the process. So if a form of physical discipline, like quote unquote spanking, results in an injury, that is no longer legal physical punishment. That has crossed the line into abusive injury. And so, I know, at least for me, when I was in pediatric training, I was never actually clear on that. I don't think that was something that was taught to me. And we've seen a number of cases where children have presented with pretty extensive buttock bruising and the parent admitted to quote unquote spanking. And CPS wasn't called because the provider was under the impression that spanking is legal. And that is true. Spanking is legal, but injury is not. And so if you are seeing bruising, that needs to be reported and evaluated. So these are all the things that I said already about slap marks. They do require impact from something that's flexible enough for those linear contusions to wrap around the curves of the body. So you do not get this pattern from impact with a rigid surface like that running into the beadboard wall. It has to be something flexible. So another pattern are loop marks. So this is a coat hanger. This was a charger cord, if I remember correctly. Again, you're getting a negative impression. Sometimes you will see the central sparing, but sometimes it's already resolving and looking a little smoky like it is on this child's leg. This is from a belt. These, again, require something flexible wrapping around the curves of the body. You can't run into, be hit with something rigid, or lay on something rigid and get bruising that conforms to the contours. So I think I said all of this. The most common objects for loop marks are belts, charger cords, wire coat hangers, and fly swatter handles. Then we also have another pattern injury, which is the inflicted bite mark. This we know is an adult bite mark because there was a confession from a perpetrator. But anytime you see bruising, we describe these as opposing curvilinear contusions or opposing arches. You can describe it really however you want to, but anything that sort of looks like parentheses, think about the possibility of a bite mark. These can be complete circles, like it was on the cheek that I showed you earlier of the child with the jawline bruising, or it can be these, partial arches, which look more parenthetical. We used to think that measurement could help us distinguish And by we, I mean the medical community, used to think that measurement would help us distinguish between adult bite marks and child bite marks. That turns out not to be the case at all. There are a number of adults who just have smaller than average mouths or who just don't open their mouths very much. I'm actually going to, let's see. Yeah, good. I have a picture of her. So this is the one that I showed you earlier. This is what was used as the size standard by the outlying facility when she came in. So a quarter is exactly an inch in diameter. And everyone who saw this bite mark assumed that it was from another child because of how small it was. However, this child had not actually had contact with any other children. Her father did ultimately admit to biting her on her face when he was in the ER with her, and he violently shook her as well. So she came in after what we then called ALTIs. We now call them bruise or bruise, brief resolved unexplained events. So she had a temporary loss of consciousness at home. She woke back up and was actually looking pretty good by the time EMS got to her. EMS did absolutely the right thing by transporting her to the hospital anyway, because she had had a loss of consciousness, which essentially was a concussion from her violent shaking event. This is the little girl whose ear bruise I showed you earlier, who was in the PICU with the liver laceration. This is the bite mark she had on her cheek. This is a little gal with bite mark there. And then these are actually the same children a year apart. When this happened to him as an infant, it was not recognized as a bite mark. And the case was closed. It happened again, and it was recognized that time. And actually, for these three on the bottom, mother was the perpetrator. For bite marks to the face, in my clinical experience, and this is not something that I've seen published anywhere, but when it is facial bite marks, more often than not, it's a female perpetrator. And I just find that interesting. So we get really worried about bite marks if they're caused by adults because they tend to indicate a more sadistic abuser. I think most of us on some level can understand the frustration and the impulsiveness that can be involved in a violent shaking event or in an event where someone hits a child and causes injury. However, biting another human when we're adults is not a normal impulsive act. It actually requires some degree of planning. It may only be a second or two, but we have to position ourselves and the child. And there's enough time for our frontal lobe, to help keep us from doing that, unless we're really, truly, frankly, doing it on purpose to hurt the child. And that's why we worry so much about these. If we catch them when they're relatively fresh, we can actually swab them with the swabs from a rape kit or an evidence collection kit. And sometimes that can be helpful to the investigation. We have to remember to take pictures. And then, of course, we do have to remember that not all bite marks are caused by adults. Many of them, if not most of them, are caused by other children. It is helpful to obtain the history very clearly about who the child has been around, whether the child even has contact with other young children, and documenting that clearly. And then one other pattern injury that we see is sometimes referred to as Feldman's lines because Ken Feldman was the one to first describe it, but it's these vertical linear contusions that go along the gluteal cleft. You can see this infant has extensive bruising to her buttocks as well, but it's these bruises that I'm talking about. And those are coming from a direct blow, usually with an open hand or some other object that is hitting so hard that it's crimping the edges of the buttocks together in a crush injury. And so these get sometimes mistaken as loop marks or from a belt because they're linear, but it actually just comes from a direct blow that just speaks to the velocity and force of the impact. So pivoting now to what is normal, typical bruises on mobile, active children tend to be on the front of the body and over bony prominences. So foreheads, elbows, knees, and then the shins get the brunt of it. You can have, 20 or 30 little fingertip sized bruises along the shins of an active mobile toddler, and that can be completely normal. Forehead bruising is not usually concerning unless it's present in clusters, or we get more concerned the farther back it gets, closer to the hairline, because children usually are not falling on that part of their head. It tends to be the fronts and the sides that tend to impact when they fall. And then no discussion of bruising is complete without mentioning this incredibly common birthmark that we see in children of all different skin pigmentations, called slate gray nevi or congenital dermal melanocytosis. And these are most often on the buttocks and the low back, which is, as you know, a target area for abuse, so they get mistaken for bruising. Usually we can tell by looking, just because we're experienced in making the distinction, but some of the clues that these are birthmarks is that they tend to be very uniform in color. They don't have the variation of color within the specific lesion that a bruise usually will have. If you're ever in doubt, we can take pictures on one day and then take another set of pictures a day or two later. If it is this kind of birthmark, it will look exactly the same. If it is bruising, it will change in some way. Now, we can't predict what color bruises will be, and we cannot date bruises by their color. But what we can say is that bruises do change over time. And these are just some examples of CDM on children with much lighter skin, just to prove that it does happen in children with lighter skin as well. It is not specific to any one racial or ethnic group, and these can actually look a lot like bruises. And sometimes we have kids that have these birthmarks and bruises, and so we do serial photography to distinguish between the two. And as you can see here, they are not only on the back and buttocks, they can be anywhere, including the face, hands, arms, legs, etc. So we get common explanations for bruises sometimes when they show up in babies, and I'm only giving you these just because they are so common, and just to, plant the seed that if you hear these explanations, kind of take them with a grain of salt. If it falls within the 10-4 faces P bruising rule, it needs a workup. We hear that kids sleep on toys or pacifiers all the time as an explanation for bruising to the soft portion of the cheek. Again, you can't lay on or be hit with something rigid and get a patterned injury that wraps around the contours of the body. And laying on something, if you are neurotypical and are able to shift your weight the way a neurotypical person does, even when they're sleeping, does not result in bruising. It may result in temporary indentations or redness, but it will not actually result in a bruise. Kids having tummy time and that their head bobs, during tummy time, and that they somehow hit a toy or the floor hard enough to cause a bruise, not really something that we see. Bruises to the soft portion of the cheek or to the chin or neck from holding the face for nasal suction or med administrations. Routine, interactions with kids to hold them for that kind of stuff, if they do not have a bleeding disorder, is not going to result in bruising unless there is violent force applied. The pinch in the car seat strap has come up many times, as well as hitting the child's head on the handle of the car seat or the door frame. Some of these, especially these last two, actually can be plausible, but they also can be abusive. And that is why we don't have to, by we, I mean anybody other than the child abuse team, we don't have to try to figure out if the explanation is plausible or not. If it falls within 10-4 faces P, we do the workup. So we spent a lot of time talking about bruises because bruising is the single most often early warning sign for abuse. And when we have children who come in with abusive head trauma, who have evidence of prior injury, bruising is the most commonly overlooked sign. So sometimes we find out that the child has had bruises in the past because we ask that question, or parents will have pictures of the child with bruising in the past. And oftentimes we have evidence of bruising in babies in the medical record where providers have seen the kids, seen the bruises, accepted the explanation as plausible, and not gotten the workup. And then the children come back with abusive head trauma. An alternative response that we see sometimes is that providers, rather than sending the child to the ER for the full workup, will send the child to hematology as an outpatient. I've had 2 patients in my career who had that happen. They went to a PCP. PCP arranged for a hematology consult because they thought the bruising was indicative of a bleeding disorder, and the child was killed between the time that the bruise was identified before they could get to hematology. And that's just one person's clinical experience. Vomiting in the absence of diarrhea certainly is not specific for abusive head trauma, but we need to keep it on the differential diagnosis in children who are having persistent vomiting, especially if no one else at home is sick. If it's persisting, for more than a day or 2, if it's not consistent with what we usually see with reflux, it's appearing, out of nowhere, especially if it has an acute onset. All of that are things to take into consideration when deciding when to do head imaging. Poor feeding, poor weight gain, the brief resolved unexplained event. Again, we used to call these ALTs, apparent life-threatening event. Now they're called BRUIs or bruise. And abusive head trauma is absolutely, on the differential diagnosis for these. Seizure in the absence of fever. Sudden increase in head circumference, crying and irritability. Sometimes we find abusive head trauma because we do a chest x-ray for another reason. We find healing rib fractures, which then prompts a head CT, and that helps us find the subdurals. Sometimes when the event is severe enough, you can have severe enough diffuse brain injury that children will become apneic and completely stop breathing. They can also go into full arrest, and it can even die before EMS arrives at times. Other things to keep in mind as presenting scenarios: bright red blood from the mouth of babies, the torn frenulum, and we also sometimes can see soft palate, tonsillar, and pharyngeal lacerations that are inflicted, as well as esophageal perforations have been well described as well in abuse. So let's talk some about the medical evaluation. And I'm going to just pause for one moment and say I'm looking at time, and I'm pretty sure I'm not going to get through all of the slides. I believe a handout version of this is going to be made available that doesn't have the photographs in it. So I would encourage you to download that and check out the rest of the slides, since I'm pretty sure I'm not going to get all the way to the end. But now back to the medical evaluation. If we have a child where we are suspecting abusive head trauma for any reason, and that includes bruising in babies or any of the combinations of signs or symptoms that we just talked about as a presentation, the first line is to do a head CT. Head CTs will help us identify acute subdural bleeding. If the brain swelling is severe, we will see that on CT. But many times, even with significant traumatic brain injury, you will not see abnormalities to the brain tissue itself on CT. And sometimes you won't see it on MRI either, although MRI is much more sensitive for parenchymal brain injury. We also do a skeletal survey. We do skeletal surveys for kids under 2, where we are concerned about abuse. It's a standard part of the workup. It is not the same thing as a babygram. So if you are joining us from a non-pediatric facility, sometimes we will see those facilities just take 1 or 2 x-rays of the whole baby. We will miss abusive fractures by doing that. An actual skeletal survey is 21 different images, and they are coned in and much more sensitive for some of the subtle fractures that we can see with abuse. And then part of the workup that often gets overlooked is that follow-up skeletal survey. I prefer to wait the full 14 days, and that will help us pick up on fractures that are now healing and visible that we couldn't see when they were acute. If we have an abnormal head CT or MRI, then we recommend a dilated fundoscopic exam by ophthalmology, because we're looking for retinal hemorrhages, retinal schisis, and retinal detachment, that can all be associated with trauma. Some centers will do eye exams even in the absence of abnormal findings on neuroimaging. I personally have not found that to be helpful. So generally, I will only recommend an ophthalmology exam if we have an abnormality on CT or MRI. Also, part of the immediate short-term medical evaluation when children are sent to the emergency department are occult trauma labs that include screening for occult abdominal trauma with AST, ALT, amylase, lipase, but also bleeding labs. So just a standard CBC so we can check the H&H and platelets, as well as a PT and PTT. And those help us screen for other things in our differential diagnosis, such as bleeding disorders, but also for occult trauma. If there is any abnormality on the head CT at all, or if you still have a high index of suspicion based on how the child has presented, we go on to do an MRI of the brain and the spinal cord. The spinal cord is a new addition, probably in the last 10 years or so, maybe 8 years. It started out with us just doing the C-spine, but what we actually learned from the research is that when we see spinal injury in children associated with abusive head trauma, it most often is in the thoracolumbar spine, not in the cervical spine, when we're talking about cord injury itself. Now we can get ligamentous injury around the cervical spine that the MRI will pick up. So we do MRI, brain and spinal cord for any abnormal CT, or anytime we have a high index of suspicion. We take photographs, we report to CPS, and we consult a child abuse team. So just a little more detail. We do head CTs standardly for any child with bruising under 1 if they're not cruising. For any child with a fracture under 1, I also recommend it for any child with a burn under 1. And then I also, we also will often recommend it for children over 1, depending on what their presentation is. If their presentation has involved a loss of consciousness, like a bruit, I would definitely recommend the head CT if you have vomiting, essentially anything that's making you think there's something going on in there. We will do skeletal surveys sometimes in kids over 2 years of age if they are nonverbal, if they have special needs, if they are severely injured, / tortured, because sometimes they have so many injuries they can't communicate to us where all they've had injuries. So there are some times we do it on older kids, but mostly skeletal surveys are just done on kids under 2. If the AST and ALT are above 80, we do an abdominal CT. And that is not an ultrasound, because ultrasound is not sensitive enough for forensically significant injury. So let me talk just a second about that. Most of us are taught about abdominal CTs and labs in our exam for the purpose of identifying clinically significant injury. So these are injuries that we need to consult surgery for, and that the child may need to go to the OR for. Those certainly need to be identified without question, but we also care a lot about forensically significant injuries. So these may be subtle contusions to the liver, or a subtle duodenal hematoma that isn't going to require treatment or surgery, but it makes the difference between whether or not we can get the child protected. And so we have a very low threshold for doing abdominal CTs for those kiddos, and the ultrasounds will miss the more subtle injuries. I've already talked about the eye exam, and the last part of that occult abdominal Trauma labs are a bag urinalysis because we're looking for blood. And if we catheterize the child to get that specimen, we are introducing trauma and we won't be able to interpret microscopic blood. I just talked about all of this with the forensic versus clinical significance, so I'll skip that slide. Common missteps that we see sometimes are abnormal head CTs that aren't followed by an MRI. And just understand that many of these things are things that we see when children are evaluated at non-pediatric facilities, oftentimes by providers who aren't pediatric trained, but are taking care of children nonetheless. We will see skeletal surveys that don't get a follow-up in 2 weeks. We see documentation that there are retinal hemorrhages, but there is not a description of how many, where they are, and how many layers they're in. Those are all things that are very important to help us decide how specific the retinal hemorrhages are for abusive head trauma. A few isolated retinal hemorrhages in the posterior pole are not particularly specific for abusive head trauma, whereas too many to count multi-layered retinal hemorrhages extending to the periphery are very specific. And then doing the babygram instead of the complete skeletal survey. And here is just one example. This was a baby that came into an adult emergency department with swelling to the arm, no history of trauma, no bruising. They did a babygram here. And they did actually pick up on a cortical disruption here. So thankfully, this babygram didn't miss the injury, but it did not show the injury to nearly the same degree as an actual skeletal survey image showed it. So this looks like a little cortical disruption. This is a comminuted midshaft acute humerus fracture. So either way, in a baby, that's going to be highly concerning for inflicted injury. But please know that there is a difference in quality and sensitivity between a babygram and a complete skeletal survey. Take lots and lots of photographs as soon as you can, and please don't try to date bruises. Even saying things like these bruises look old or they look like they are in various stages of healing sometimes can cause confusion. Because different bruises inflicted on the same person at the same time during the same assault may evolve at a different rate and go through different color changes. So just because they're all different colors doesn't necessarily mean they didn't happen all at the same time. So we are better to just describe shape, size, location, whether it's tender, whether it's swollen, what color it is, and stay away from any attempt to date the bruises. I had to memorize this when I was in medical school because we thought this was true. And like many things that we were taught in back in the day, it turns out not to be evidence-based at all. So bravo to evidence-based medicine for teaching us to not do this anymore. Just a couple things about radiation exposure, because this comes up often out in the state, again, at non-pediatric facilities where folks are very reluctant to perform the necessary radiologic studies to screen for abusive injury. And I think it is absolutely appropriate for us to consider radiation exposure and cancer risk every time we are considering whether to do a radiology study. However, it is important to recognize that the increased cancer risk that we are concerned about with radiation exposure is essentially theoretical. We don't have great data, that tells us that kids that got a lot of x-rays are actually at higher risk of getting cancer. It's a theoretical risk. On the other hand, the risk of a fatality, if we miss child abuse, has been estimated in various different ways and it lands pretty clearly around 10%. That's not theoretical. That's a fatality rate that's higher than, appendicitis being missed. So the risk of missing abuse resulting in a fatality or near fatality greatly outweighs the theoretical risk of the X-ray exposure when there is a true indication. So pivoting just a moment here in the last few minutes, we'll talk just briefly about outcomes. About a third of these kids, a quarter to a third, will die. And if they live, they can have pretty extensive and significant neurological long-term injury. That's about half of the kids who live. The other half of the kids who live will do actually fairly okay and will be able to function relatively normally. Even among those groups that are, or those children that are seeming to function normally, when we do formal cognitive and other forms of developmental testing, 90% of them will have some identifiable issue. So the chances of surviving abusive head trauma with no long-term effects whatsoever are less than 5 to 10%. So what we often see in kids with severe brain injury is they lose their ability to feed safely orally because they can't protect their airway, or they don't have the motor coordination anymore to suck and swallow. One thing about this is that if babies are injured before 4 months of age, that suck and swallow is still a reflex. So they may appear, or they may actually be feeding well and feeding safely while they're in the hospital. But then once they go beyond 4 months, that reflex will extinguish and they will suddenly lose their ability to feed adequately and then need a G-tube placed. They often are placed on long-term medication. It can be for seizures or to prevent and treat contractures. Often they need reflux medications as well. They need all the therapies. They may have vision or hearing effects. Often have to follow up with multiple specialists, orthopedic surgery, PM&R, neurology, neurosurgery. And I already mentioned the risk for long-term developmental problems. Establishing a medical home for these kiddos is critical. Counseling caregivers about trauma-informed parenting and how these kiddos can react to times of transition during their childhood and even their adulthood is helpful. And then remembering older siblings to get them evaluated for physical abuse, but also to get them mental health, as they may have witnessed violence in the home or experienced it themselves. I've already mentioned the most common triggers as crying and toilet training. I'm going to go quickly through some of these because I want to get first to unrealistic expectations is the most common predictor of, that's not what I'm trying to say. Unrealistic expectations is the most common thread that I have found in my career that runs through cases of physical abuse in young children. Folks simply do not understand what children can and cannot do at certain levels. Developmental levels. So I'm going to go through this case quickly. It was basically a 4-month-old that presented with bruising, and the question is, what should this provider do? Actually know the family presents well, no red flags, yada, yada, yada. They should send them to the emergency department. Unfortunately, that did not happen for this child. This was the very first patient I ever cared for as a resident who had abusive head trauma. And this was back when we still faxed medical records. And I remember sitting in the PICU and those medical records were coming from the pediatrician and looking at them and seeing that the child had presented with bruising a week prior. And this was way before we had the 10-4 research and before we knew widely what a significant issue bruising in babies is. It was documented by the pediatrician that the family was very nice. There are no concerns and the family was appropriate. And the child came in seizing, bilateral subdurals, 13 broken bones. Bruising in babies isn't normal. Maltreatment can and does occur in quote unquote nice families. The absence of risk factors is not the same as the absence of risk. And I am going to quickly talk about this slide just because implicit bias is very real. It has been borne out in the research. We are more likely to overlook abuse in people we perceive to be similar to ourselves, and we're more likely to suspect abuse in people we perceive to be different. I'll let you read the slides on documentation and kindness and rapport. I do want to talk very quickly because it's one of the questions about mandatory reporting in Kentucky. So we have actually one of the most inclusive and broad mandatory reporting laws in the country. It is any person who has a reasonable cause to believe. So in some states, it's just certain professionals who are required to report. In Kentucky, if you're a person, you are legally required to report, and you do not need to be sure. If you are waiting to report only those cases where you're sure it's abuse and neglect, you're missing cases. So it's kind of like the surgeons wanting to get a certain percentage of their appendectomies to have normal appendices, so that we know we're not missing some. The same applies with reporting suspected child abuse or neglect. So you can report by calling the number. You can report during normal business hours. If you're a professional, actually through the web, but that is not appropriate for urgent reports. Make sure you share everything you know when you make the call. The person with the firsthand information should be participating in the call. They can do that with the hospital social worker, but I always encourage residents to participate in those calls as well. If they can. I understand that patient flow sometimes presents that or prevents that from being feasible. I am just going to run through to make sure I covered everything that I wanted to cover that was super important. If we're going to talk about prevention, secondary prevention is recognizing the signs before it gets really bad. So that's where recognizing the bruising in babies. Primary prevention is helping caregivers have realistic expectations for children, including talking to them about crying, the dangers of shaking, and that bruising in babies is not normal. And I will stop there. I know I went a few minutes over, but hopefully we still have some time for questions.
All right, I think we have some little time. I got some questions for you. Okay, so if we were doing a routine well child check and find a bruise that is unexplained in an otherwise stable child, should they be transported via EMS for the exam, or what's the best way to go about that?
That's a fantastic question and one of the most common questions I get. So I think that it depends on how the family or caregiver reacts to you saying that the child needs to go to the emergency department. If they are concerned and packing up the diaper bag and they're ready to go, I think it's perfectly okay to let them drive the child to the ER. But what I recommend telling them is that I don't want you to panic and drive 100 miles an hour, but I don't want you to go home and pack a bag either. I want you to go straight from here to there. I'm calling the ER. They will be expecting you. If there is any pushback or reluctance at all, then yes, I would have EMS transport them. And certainly if the child's not stable in other ways.
Okay. And so if you photograph the bruises, but you don't have a office camera in your office and you use your personal smartphone, is that smartphone then legally exposed to some sort of subpoena or involuntary search by authorities as potential evidence? Assume the photographer is a licensed provider seeing the child in an outpatient office and the area photographed, for simplicity's sake, is not genitals or buttocks.
Yeah. The answer is yes. If you take a picture on your personal cell phone, not using a Haiku app, that's a critical difference. You're not using Haiku with Epic. If it is stored on your phone, even if you download it to a safe and secure place, they still, in theory, could subpoena your phone. So I highly recommend being proactive and getting a camera in your office or getting the Haiku app on your phone. Now with Haiku, The phone is basically the portal for the picture to go directly into the medical record. That photograph is never saved on your phone. And so if you're using Haiku, your phone is not at risk. And the person asking the question is spot on. Never, ever, ever take pictures with your personal cell phone of genitals, even if it's bruised and it needs to be documented. Just figure out a different way to do it, unless, again, it's Haiku.
All right, that's good information. What do you do if you have identified a child that needs to be reevaluated in 2 weeks, but they don't return?
So that is part of the service that our team provides when we get involved in these cases, is that we follow all of these kiddos and try our best to make sure they do come back for the follow-up. We will work with CPS and sometimes with police. We sometimes get court orders. Sometimes if families are refusing to get it done, depending on the situation, that will be the reason the child ultimately gets removed from the family. So it is part of the medical evaluation. It is not optional. And so we will help do our best to make sure that happens.
All right. All right, very good. Learned some things that was very interesting. I hadn't thought about the charging cord as being a weapon like that, but of course, everyone has a charging cord, right?